So let's go ahead and take a look at some pathologic states because this is really what matters to us as nurse practitioners. First of all, let's look at the difference between hypoxia and hypoxemia. Hypoxemia, very simply, is decreased levels of blood oxygen. Hypoxia is decreased tissue oxygenation. They frequently go together, and sometimes we use the word synonymously, but they are somewhat different. Hypoxic hypoxia is the decreased availability of oxygen in something like high altitude or obstruction. So you could have hypoxia, decreased tissue oxygenation in a specific area without necessarily having hypoxemia. You might have normal tissue, normal levels of oxygen in the blood elsewhere, but just simply be hypoxic within a specific tissue. Anemia is a cause for hypoxia. We do not have enough red blood cells to transport oxygen, and therefore we're just not getting enough oxygen to our tissues. Circulatory hypoxia, we could have insufficient blood flow to areas to actually carry in the oxygenated blood. So it's not that our blood's not oxygenated, it's that we can't get it to the areas that it needs to be at. And we could have toxic situations, histotoxic, something like cyanide or carbon monoxide poisoning, where the red blood cells are perhaps binding to carbon monoxide in preference to oxygen. And so while we are transporting something, we're not actually oxygenating our tissues. So our tissues become hypoxic. When we talk about lung disease, there's really three primary types, and this is important to know. We have what's called restrictive lung disease, obstructive lung disease, and circulatory lung diseases. Restrictive is your central little glass picture there. Your lung size is smaller than it should be. You have a reduced volume and you have reduced ability to expand and to recoil. An obstructive lung disease, on the other hand, you actually have a normal lung size, you have normal expansion and recoil, but you have something that is actually obstructing the airflow into and out of the lungs. And you can think of this as you have a tiny little straw trying to get into a normal-sized glass. Whereas with restriction, you may have a normal straw, but you're getting into a smaller glass. A normal lung, on the other hand, you should have a normal-sized straw, your airway in and out, and you should have a normal-sized glass, which is actually your lungs. Circulatory is, like we mentioned previously, is your perfusion side of things. And that is simply, are you bringing in enough blood to pick up the gases that are being exchanged and diffused back and forth across the alveolar membranes? So that's your third category. We're going to be predominantly focusing on restrictive and obstructive lung diseases, although circulatory would be something like a pulmonary embolism. So which is which? So when we look at these, acute bronchitis, asthma is a very class of obstructive disease because your lungs themselves are normal in size, but you're essentially constricting the passageways that come in so that you can't get the air in and out. This is going to be true for your bronchiolitis. COPD is also an obstructive. That's why it's chronic obstructive pulmonary disease. Cystic fibrosis, on the other hand, is restrictive in that it's actually causing fibrosis or scarring of the lung tissues that restrict the size and the movement of the lungs. A DVT that transmits as a pulmonary embolism is going to be more of a circulatory type of disease. So you can see that there's a lot of different things. Lung cancer is probably going to be a combination of restrictive and possibly a little bit of obstructive as well. Pneumonia, that is going to be largely obstructive because you haven't necessarily completely scarred the lungs or changed how much they can move. So chronic lung diseases are one of the biggest killers still globally as well as in America. Within the top, I think it's number 4. About 15.7 million adults in the United States are affected by some type of a chronic lung disease. And it's estimated that the estimates range. That was a 2014 range. There's actually estimates that up to about 25 million people have asthma and a chunk more with COPD and etc. COPD, emphysema, asthma, and chronic bronchitis are kind of the big four. And these are responsible for a lot of emergency department admissions, fourth leading cause of death. Estimates range from 32 to 50 plus billion dollars annually in expenditures. So if we take a look at a case here, we have a 2-year-old male child who presents to the emergency room for sudden onset of wheezing and difficulty breathing. He's conscious, but he's pale and has increased work of breathing. What could it be? What are the possible mechanisms of dyspnea here? So obviously one of the first things that you'd want to consider in a kid who comes in with sudden onset of wheezing and difficulty breathing is foreign body. Did they inhale something that's in their lungs that is obstructing? If that's not the case, are they sick? Are they viral? Could this be a bronchiolitis? And they have inflammation within the airways, which you would treat with something like a steroid. Or is this an asthma type presentation? So asthma in the United States affects approximately 8.3% of our entire population, 25 million people, 6.3 million children. African American individuals are at much greater risk. They have a higher prevalence of asthma, and they also have a higher risk of hospitalization and death. And this is attributed to kind of socioeconomic disparities, housing conditions, as well as quality of health care that they receive. Puerto Ricans also have a higher prevalence as well. So when we think who's most at risk, it's going to be our African Americans, certain of our Hispanic populations, Puerto Rican specifically, and then our Caucasian following that. So estimated cost of asthma in the U.S. about $56 billion annually. 1.8 million ED visits, 500,000 hospitalizations, somewhere in the range of 3,500 to 5,000 deaths annually. So a pretty big impact. This table just shows the kind of disproportionate burden of asthma between African American, white, and Hispanic Latino populations. And you will notice that the African American is the highest, the white is the second, and then Hispanic Latino. That is a blended number. If you separate out Mexican from Puerto Rican individuals actually have a much higher risk of asthma than do Mexican individuals. It's a little bit unclear as to how much of that is environmental exposure, genetics, or culture. But either way, the most at-risk group is going to be your African American individuals. When we think of asthma, we want to think of this as a chronic inflammatory disease of the airways that is usually reversible, characterized by inflammation, reversible obstruction, and bronchial hyperreactivity. And these are the big hallmarks that you will want to know about asthma: inflammation, reversible obstruction, and bronchial hyperreactivity. I translate this for patients into SOS, swelling, obstruction, and spasms. Inflammation is a form of swelling. So you essentially have this silent underlying inflammation that nobody really feels. And then you have this reversible obstruction, which is a combination of bronchospasm and increased mucus formation within the airways, and then the bronchial hyperresponsiveness, which is your spasms. This is the national NHLBI, National Heart, Lung, and Blood Institute guidelines definition for asthma: inflammation, reversible obstruction, and bronchial hyperresponsiveness. So when we think pathophysiology of this, essentially, inflammation, we're talking about eosinophilic and IgE mast cell-mediated disease for the majority of patients. However, this is not true for everyone. We have essentially two types of disease, which we'll look at on the next slides, which is allergic versus non-allergic asthma, also referred to as atopic and non-atopic. The second characteristic is the airflow obstruction. So we can have acute bronchoconstriction, which is smooth muscle constriction around the airways. We get airway edema, which actually causes swelling of the airways and causes the airways to be reduced in size. This causes a chronic mucus plug formation, further obstructing the airways, which results in our kind of overall airflow obstruction, specifically during during expiration. So it kind of leads to a little bit of air trapping. It's harder to breathe out, which is why you have that wheeze when you breathe out. Hyperresponsiveness is essentially an exaggerated bronchoconstriction response. So the smooth muscles around the airways become very irritable. Our receptors are more prone to bronchoconstriction, and we end up with the classic signs of chest tightness because the smooth muscles have constricted. We're further reducing the size of the airways, and we're further lending towards the wheezing. The final thing that a lot of people are not always aware of with asthma is that asthma is associated with what is called airway remodeling. That as these chronic issues with inflammation persist over time, we are essentially damaging cells within those areas, and we're causing the buildup of microscopic scar tissue. And we're changing over types of airway tissue from one type to another. So we start getting thickening of the airway walls as well as increased smooth muscle mass, and we've permanently changed the structure of our airways over time. So a lot of times people think of asthma as just, oh, it's a bothersome symptom that will go away. But in actual fact, asthma, when it's uncontrolled, is associated with permanent, irreversible airway remodeling. So this next slide is just showing us the different types of asthma phenotypes. It used to be that when we thought of asthma, we just thought of asthma, it's just one thing. But we're now starting to realize that asthma is not one entity. It's actually kind of a heterogeneous or a multiple grouping type of syndrome. And if we break it down essentially into 5 or 6 different kind of phenotypes, which is the clinical manifestations of disease. So we have what is called our atopic or allergic and our non-atopic or non-allergic type of disease. So if we look at the top, we have inflammation predominant. We have early onset atopic, mild disease. We have early onset atopic, a severe form. And then we have a late onset atopic, which is typically also a severe form. The last two, which is called early symptom predominant and late onset obese asthma, do not have the normal type of inflammation that we think of when we think of asthma. These are considered non-eosinophilic asthma. They do not go through those T helper 2 cell pathways and IgE mast cell type of inflammatory pathways. And because of that, the treatment of these is very different. So this is people who have disproportionately high levels of symptoms without associated airway inflammation. And they tend to respond very poorly to traditional treatment with inhaled corticosteroids because inhaled corticosteroids actually target that Th2 pathway, that allergic pathway. And if you don't have allergic disease, targeting that pathway isn't actually going to bring any relief in symptoms. So these two groups, late onset obese and early symptom predominant groups, are going to be at risk for overtreating with inhaled corticosteroids and traditional asthma medications with very poor response. This group actually needs a different approach to treatment and may need medications like a long-acting beta agonist, which is simply a bronchodilator, or a long-acting muscarinic agonist to give relief for the symptoms without necessarily looking to suppress an inflammatory mechanism. So this table just gives a little bit of a breakdown between these groups. Th2, asthma, is again our allergic or atopic. Allergic inflammation, as we know, is mediated by our adaptive immune system via the IgE antibodies, the T helper cells, and our eosinophils. Frequently has a very rapid onset following allergen exposure, and it can sometimes be severe or anaphylactic, although it is not in most cases. So the IgE is essentially binding to our pro-inflammatory immune cells, the mast cells like we talked about, and these trigger the release of our T helper type 2 cells, which short form is Th2, and release of histamine. And as we recall, histamine is a cytotoxic substance that causes generalized inflammation throughout that area. So the classic hallmark of allergic asthma is airway eosinophilia, eosinophils within the airway, and also sometimes we'll see eosinophil rise within blood when we do CBCs. And these are triggered by the release of interleukins from the Th2 cells. Now you may see the word interleukin and it may trigger for you a leukotriene inhibitors. So interleukins are actually the components that are being targeted when we have leukotriene inhibitors, something like Singulair. So all of the majority of our current asthma medications, inhaled corticosteroids, leukotriene inhibitors like Singulair, all of these are targeting allergic Th2 mediated pathways for asthma and work very well for people who have allergic type disease, but do not work for people who have non-allergic or non-atopic asthma. So our non-allergic or non-atopic asthma is people who start getting symptoms later on in life, and it's associated with obesity. Symptom predominant, again, where they have disproportionately high symptoms without any form of airway inflammation. And sometimes we measure airway inflammation either as eosinophils or we measure it as nitric oxide through the FeNO2 tests. And these lack that inflammatory pathology using those normal Th2 pathways. And instead they go through a different pathway called Th17 pathways. It's a completely different group of pro-inflammatory mediators using neutrophils predominantly, which increase bronchial hyperreactivity with or without actual inflammation. So really the important take-home point from this is that the cytokines produced by the Th17 pathway is not responsive to steroids. So if you give these patients steroids, they're actually not going to get better. If you give them inhaled corticosteroids, Advair, Flovent, Symbicort, they're not going to get better because they don't respond to steroids. So if you have a patient with asthma that you're treating and you're like, they just are not responding to the medication, you want to have a suspicion that they're actually non-allergic or non-atopic asthma and they may need a different approach to treatment. When we think of asthma, we also need to consider the differential diagnosis. So is it definitely asthma, or could it be a chronic obstructive pulmonary disease, which again may need as it needs a different approach to treatment? We're going to use fewer inhaled corticosteroid. We're going to use more symptom relief medications, long-acting beta agonists, and muscarinic agonists. Is it something like reflux? If you've got inflammation because of GERD that's happening in the esophagus is very close to the airways, and that inflammation is going to trigger asthma-like symptoms. If you treat the GERD, the asthma-like symptoms go away. Is this obesity? Is this chest wall mechanical restriction where the most effective treatment for the breathing is actually going to be exercise and weight loss? Is it rhinitis triggered? If you treat the allergic rhinitis and the postnasal drip, do you get fewer asthma symptoms? Is it a post-viral reactive airway disease? Is it dysphagia? You're having reflux and you're not you're not swallowing your food properly. Vocal cord dysfunction is actually a fairly common cause of asthma-type symptoms. It comes across as wheezing or coughing, and it's actually not asthma, it's actually dysfunction of the vocal cords, and that's something that's typically diagnosed by ENT. Congestive heart failure, are they wheezing and they're coughing because they have heart failure and they have a buildup of fluid in the lungs? Is it a pulmonary embolism with a very sudden onset, or could it be lung cancer? With children, you may want to consider other potential diagnoses. Viral wheezing in infancy, upper airway congestion, pinch the nose as you listen to the lungs and make sure it's just not upper airway, a foreign body aspiration, undiagnosed cystic fibrosis, a fistula between the trachea and the esophagus, a heart disease that has been overlooked, etc. These two tables just provide some potential differential diagnoses for asthma, some of which we've already discussed, cystic fibrosis, and some differentiating tests, which you can review independently. But again, just be aware that there are multiple other diagnoses, and that just because it looks and sounds like asthma does not mean that it actually is asthma. And this table here is a second one, including some further information about vocal cord dysfunction and alpha-1 antitrypsin deficiency, which is a kind of a familial sort of issue. So when we talk about asthma, it is important to recognize that when we talk about asthma being controlled or not controlled, we're essentially talking about the degree of symptoms as a marker for underlying inflammation and hyperreactivity. Patients are considered uncontrolled with their asthma if they have symptoms more than twice a week. The majority of our patients currently with asthma are uncontrolled because as healthcare providers, we're doing a very, very poor job asking them detailed enough questions for them to recognize that their asthma is actually uncontrolled. And what is currently happening is that a lot of patients are getting used to living with asthma symptoms, and when we ask them generic questions and say, how's your asthma? They say it's fine because it's no worse than it usually is. So we really need to stop asking patients, how's your asthma? And we need to ask them very specific questions such as, how many times in the last week have you had any symptoms of asthma, such as coughing, wheezing, repetitive throat clearing, chest tightness, chest discomfort, exertional intolerance, the inability to walk up and down stairs and do your regular activity. So symptoms less than twice a week, waking up less than twice a month from asthma, needing your rescue inhaler infrequently, no activity limitations, and really no steroid use, or maybe once a year, is considered well controlled. Also, a forced expiratory volume, FEV1 or peak flow, that is greater than 80% predicted is part of this, but is not as often used in the clinical diagnosis of asthma. Be careful in using rescue inhaler as a measure for asthma control, because a lot of the patients I work with are not using their rescue inhalers even though they are symptomatic. So if you simply just say, how often are you using your rescue inhaler? Oh, it sounds like you're doing good. You're going to miss a lot of people who are actually very symptomatic and that you have no clue because you just asked about the rescue inhaler. So that is not a good measure for asthma control. National guidelines provide some very specific charts, which you will see later when you get into asthma in the nurse practitioner classes, on how to diagnose severity of asthma and how to diagnose control. Again, we have a tendency to be very sloppy in how we approach asthma, and we assume that, oh, it's a very simple to manage disease. It is not actually a simple disease to manage well. It's very straightforward. There's very clear guidelines. If we are following them, it's very easy to get patients managed, but a lot of times people are not familiar with these guidelines and they're not actually following them. So severity is diagnosed by the frequency of symptoms as well as lung function. Asthma control, again, is diagnosed by the frequency of symptoms, and there's a well-controlled, a not well-controlled, and a very poorly controlled group. So when you are documenting on asthma for your clinical notes, you should document, is this mild, intermittent asthma? Is it mild persistent? Is it moderate persistent? Or is it severe persistent according to the guidelines? And you need to have a second documentation of, is it well controlled, not well controlled, or very poorly controlled? So this is very, very important. You should know this. Every time you document about asthma, mild, intermittent, mild persistent, moderate persistent, severe persistent, and what is the level of control. Case number 2. We have a 60-year-old coal miner who comes to the office complaining of feeling short of breath all the time, particularly when exerting himself. What could it be? What are the possible mechanisms of disease? Well, coal miner, he's got a lot of environmental exposures. If we add to it that he's a smoker, then the most obvious thing that's going to leap to our mind is going to be chronic obstructive pulmonary disease, as this is the biggest chronic obstructive disease in adults. This is a very common preventable disease characterized by persistent respiratory symptoms and airflow limitations that is partially reversible. And that is why it's considered chronic obstructive. It is not fully reversible. It is the 4th leading cause of death globally, and is projected to become the 3rd leading cause of death by 2020. So when we talk about the prevalence of COPD, we're saying somewhere in the realm of 384 million cases in 2010. Global prevalence somewhere around close to 12%, 3 million deaths annually. And this is a largely preventable lung disease, heavily related to smoking. Smoking is our biggest cause for chronic obstructive lung diseases and environmental type exposure, occupational exposures. The most common respiratory symptoms of COPD are going to be dyspnea, so that is a perceived shortness of breath, cough, and sputum production. Symptoms like this may, again, be underreported by patients, so we really need to be careful how we ask them about symptoms. The main risk factor for COPD is tobacco smoking, but as we said, the environmental exposures, such as coal mining and air pollution, will definitely contribute. So when we talk about etiology, etiology is kind of the underlying risk factors are smoking and pollution, as well as host susceptibility. And then we have the pathophysiology, which is impaired lung growth and function and lung injury over time, leading to our pathology, which is our airflow limitation and our clinical manifestations of COPD. This is a chart that's just showing forced expiratory volume. FEV1 in 1 second essentially is your predominant measure of lung function. How fast can you blow out air in the first 1 second? It's a way of measuring obstruction and restriction. And so this chart shows that anybody who is it's just kind of showing progression over time in people who don't have COPD versus people who do have COPD. And you'll notice that over time there's a kind of a progressive worsening of the forced expiratory volume and the lung function that is greater in COPD groups than in patients without COPD. So after age 20, everyone does start to go downhill a little bit. We kind of reach our peak lung function generally in our 20s, and then we start to slide downhill. But the slide is more gradual for patients who do not have chronic obstructive pulmonary disease. Again, the underlying pathology of this is chronic inflammation that leads to permanent structural changes or remodeling of the airway. This is believed to be due to oxidative stress and the inflammatory cells, which are very similar to those in asthma and inflammatory type mediators. And then what happens over time is we start getting interstitial fibrosis or scarring of those interstitial spaces, which leads to kind of restriction. We start tipping over from just being obstructive to actually starting to get into a little bit more of a restrictive lung disease. So pathophysiology is we have airflow limitation with gas trapping that happens after time. We start to have gas exchange abnormalities because we've changed the membrane thickness, we've changed the elasticity and the recoil of the chest. We've got mucus hypersecretion, so we do not have as good of an ability to diffuse gas across because we've obstructed our airways, and it can also lead to pulmonary hypertension because we've altered the circulation into and around the lungs. When we are diagnosing and doing our initial assessment of COPD, we want to consider this diagnosis in anybody who has shortness of breath, chronic cough, or sputum production, and a history of risk factors. So essentially we're going to take a good history of symptoms, and then we're also going to do a spirometry test, a pre-post bronchodilator spirometry test, where we're looking for a forced expiratory volume to forced vital capacity ratio of less than 70%. And we're going to go into spirometry a little bit more, but basically, again, forced expiratory volume is the amount of air that you can push out through your lungs in the first 1 second. How fast can you breathe out if you just huff it out? And then the forced vital capacity is what is the full, complete air capacity of your lungs that you can push out. So it's you take the deepest breath in that you can, and you blow it out hard and fast, and you keep pushing, 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 pushing. What's the total amount of air that you can breathe out? So the first number is more of a measure of obstruction, and the second number is more of a measure of restriction. Is your lung holding as much air as it should is the FVC, and the FEV1 is can you push it out as quickly as you should be able to. So the goal of a COPD assessment is to determine how bad is your airflow limitation and how likely is this to impact your health, and how likely are you to have future adverse events as a result of this, being hospitalized or dying from it. And this is what helps us to guide therapy. So when we're diagnosing COPD, we're going to look at symptoms, we're going to look at risk factors, and we're going to look at spirometry. Key indicators for considering a diagnosis of COPD, again, dyspnea, that perception of shortness of breath that is progressive over time. Characteristically, it's going to get worse with exercise, and it's going to be persistent. Do you have a chronic cough? It could be intermittent, unproductive, and you may or may not have a wheeze. And do you have chronic sputum production? Risk factors are going to be host factors. Are you genetically susceptible to it? Do you have any congenital or developmental abnormalities? Are you a smoker? Have you ever been a smoker? Are you exposed to smoke on a regular basis from home cooking, heating fuels, etc.? And do you have any significant occupational exposures, such as vapors, fumes, etc., that might predispose you to a COPD? Also, do you have a family history of COPD? Because that is another risk factor. Other causes of chronic cough, as we mentioned for asthma, is going to be lung cancer, asthma, tuberculosis, bronchiectasis, heart failure, other interstitial lung diseases, cystic fibrosis. It's going to be less likely that you're diagnosing cystic fibrosis for the first time in adulthood, but that should still sit there. Could also consider what are called the extrathoracic factors, and that is chronic allergic rhinitis, postnasal drip, GERD, gastroesophageal reflux, and ACE inhibitors. Again, coming back to spirometry, which is our lung measures of lung function, a normal spirometry, an FEV1 is going to be somewhere in the range of, say, 4 liters per minute with a forced vital capacity of 5 liters. So in the first minute, you would expect to breathe out approximately 80% of your total airflow. So a 0.8. Anything above a 0.8 is considered normal. With an obstructive disease, such as chronic COPD, you're going to start to get a ratio of your forced expiratory volume to your forced vital capacity that is going to drop below 70%, 0.7. And the more that it drops down, the more that we're indicating obstruction. How reversible that obstruction is helps to determine, is this COPD or is this more of an asthma type pathology. Classification of airflow limitation, we have the GOLD guidelines, the global, the global something for lung disease. I forget exactly what it stands for. But these are the classic COPD guidelines, and they categorize COPD as either mild, moderate, severe, or very severe. So categories 1 through 4. Mild is you have COPD type symptoms, but you have an FEV1 that is greater than 80% of predicted. Moderate is going to be 50 to 80% of predicted. Severe is going to be 30 to 50% of predicted, and very severe is less than 30% of predicted, meaning that when you breathe out initially, you have enough obstruction that you can only breathe out 30% of the air you should be breathing out in the first second. Another important thing to consider when we're thinking about COPD is chronic bronchitis and emphysema. These are closely related, and these are infectious kind of superimposed kind of infectious and inflammatory processes that come on top of COPD. We call these kind of the blue bloaters and the pink puffers, so they're old and thin. But the pathologic changes are a little bit different. So chronic bronchitis is more inflammation of the upper bronchioles, whereas emphysema is kind of fibrosis, narrowing, and scarring of these smaller lower airways. Work of breathing goes up for both of these patients, but is worse for those with emphysema. Apnea. is essentially just cessation of respiration. And this can be central or diaphragmatic. So again, you can have diaphragmatic fatigue in infants where the brain is still saying to keep going, but we have completely fatigued our diaphragm and we're no longer able to move it up and down. It can be obstructive due to upper airway obstruction or mixed. Apnea can be normal for short periods of time, central apnea up to 15 seconds. At all ages, more predominant in younger babies. We do watch for sleep apnea, obviously, which is a little bit different, where you're having prolonged periods of time where you're stopping breathing, and that puts you into kind of an oxidative stress state, which is associated with a lot of other inflammatory processes, and is associated with things like accelerated heart disease, accelerated depression, etc. A pathologic apnea is an abnormal respiratory pause of greater than 20 seconds or associated with cyanosis, pallor, or bradycardia. Premature infants may have apnea as well that usually resolves by around 37 weeks of gestation. Acute respiratory failure is essentially a state of disturbed gas exchange that results in abnormal arterial blood gases. Hypoxia is considered a PaO2 of less than 60 millimeters mercury, and hypercapnia is a PaCO2 of greater than 50 millimeters mercury, typically associated with a pH of less than 7.3 on room air. So this is kind of our criteria for respiratory failure. Lastly, we're coming into spirometry when we're measuring lung function. So we've talked a little bit about spirometry. And the components of spirometry are essentially your forced vital capacity, your FVC, your FEV1, forced expiratory volume in 1 second, and then the ratio of those two. So those are kind of the three biggest and most important components to understand for spirometry. Forced vital capacity is the total volume of air that you can push out by forced exhalation. Usually most people are making it to about 6 seconds. The FEV1, like we said, is the forced expiratory volume that occurs in the first 1 second when you're breathing out as hard as you and fast as you can. And then that ratio is just kind of telling you how much can you breathe out in the first second versus how much do you have total. To interpret spirometry, you have to actually have 3 reproducible loops. So a patient breathes into a spirometry machine and you see a big rise in the spirometry, and then you'll see the volume of air out over time. You should always see what's called a normal plateau. The patient should have kind of, at the very left-hand side, you see a little bit of a downward loop. That's the inhale. And then you see a sharp upward rise where the patient is breathing out as hard and as fast as they can. And in the first second, they've achieved about 80% of their total exhale. And then it plateaus out in that they aren't really pushing out a whole lot more air. So it's plateauing. In a patient with no plateau, that indicates you don't have a good spirometry. They really aren't breathing out hard and fast initially. They're just kind of breathing out slowly. So you need to make sure that you have flow volume loops that are consistent and reproducible, preferably at least 2 reproducible events. So you'll essentially have 3 trials, and it's going to look something like this. Trial 1, Trial 2, and Trial 3. And Trial 1 and 2 are pretty consistent looking, so we're pretty good to go on this patient. So you'll see that when we look at the numbers up at the top, we have the FVC, forced vital capacity. The total liters is 3.6. The FEV1 is 2.96, meaning that we breathed out almost 3 liters in the first 1 second, and the ratio is 83%. So when we divided the 2.96 by the 3.66, we got 83%, which means that that's normal. We breathed out at least 80% of our air in the first 1 second, which indicates no significant obstruction. So when we're interpreting that, if the FEV1 to FVC ratio is low, we've got obstruction. If the FVC is low just by itself, then we've got a restrictive lung disease. So if it's low, is less than the normal limit of normal. So that's really the big important distinction. The FEV1 to FVC ratio, it indicates obstruction. and the forced vital capacity is a marker of just restriction. American Thoracic Society grades kind of the severity of a pulmonary function test. And again, this is showing just greater than 70% is considered mild, 60 to 69 moderate. This is a slightly different category than the GOLD guidelines. By and large, you're going to want to follow the GOLD guidelines for chronic obstructive pulmonary disease. But there's no reason that you can't use the American Thoracic Society guidelines if you're looking at something like asthma. This picture here is just showing different types of flow loops. And again, we start on the left-hand side by a sharp upward spike, which is the initial exhale. You're pushing out air. And then it starts to drop off into that little red curve. And then it comes down underneath the line as the patient is inhaling, and it comes back up into a loop. So that is a flow volume loop. So the first picture shows us a normal patient breathing out, coming up to the top, and then the exhalation is starting to taper off, coming down, and we have a nice little inhale down at the bottom. The second one is showing us a mild obstructive COPD, and you'll notice that the patient is breathing out a fair amount in the first 1 second, but it's kind of got this flattened or depressed continued exhalation where you see that little red arrow. And that's pretty consistent for asthma and COPD, where the flow loop is not as great and it is it's kind of squashed down on the flow loop. A severe obstruction would look like the third picture in where you see that little double arrow, and also there's some difficulty breathing in again because your obstruction is severe enough. You will notice that in the second row there's normal for age 50 years and greater, and you will notice that the after the initial kind of sharp upward spike of exhalation that the flow loop is a little bit flatter, and this is just indicating kind of that you don't have quite as of elastic of lungs as you get older, and so your flow loops tend to flatten out a little bit more. Again, this is just showing another type of part of a flow loop over time and how it looks different between obstructive versus restrictive lung disease. And you'll notice that with the obstructive, that the rise is not quite as sharp initially, whereas with restricted, the rise may be fairly sharp, but your total volume is depressed downwards over time. And again, this is a slightly redundant slide just showing the classification of the FEV1, FEC ratios to the FEV1 predicted for mild versus moderate COPD. Lastly, we'll be coming into talking a little bit about dyspnea and perception. It is important to recognize that dyspnea is actually a sensation. It is an uncomfortable perception of breathing. There are essentially three mechanisms underlying dyspnea. You can have increased respiratory effort, increased respiratory drive, meaning that your central kind of respiratory centers are saying, hey, you need to breathe faster because we have a higher metabolic demand, there's too much carbon dioxide and our oxygen is too low. Or it can simply be a change in perception. So increased respiratory effort could be you have chronic obstructive lung disease and it's a whole lot harder to breathe, versus increased respiratory drive, I'm short of breath because I feel short of breath because my brain is telling me I need to breathe faster, versus just simply my perception. People will describe this as, we could say it's rapid breathing, I feel like I can't breathe out, incomplete exhalation, shallow breathing, it's increased work, of feeling suffocated. We might hear the word air hunger, chest tightness, or heavy breathing. The causes for dyspnea obviously can be multiple. It could be pulmonary, it could be cardiac, you could be feeling dyspneic because you are not oxygenating and pumping effectively. It could be hematologic, we're anemic and we don't have enough red blood cells, so we're not, again, we're a little bit on the hypoxic side. Neurologic, we've got a neuroventilatory dissociation. It could be psychiatric. I feel anxious. Increased metabolic demand states. I've got a fever. I've got some type of a very aggressive cancer going on, or mechanical. So the sensation of dyspnea is partly sensation, partly perception, how you perceive that sensation. And then we start looking at things like how much distress does it give you, what is your response to that, and then how do you actually report that to your providers. So dyspnea is essentially kind of a circular pattern in that you feel short of breath, you tend to breathe differently, you use your muscles differently, you tend to feel more anxious, and because of that, your perception, you tend to have a worsening perception of shortness of breath, and you limit your activities and become progressively more anxious. So it's a very cyclical type of reaction. Measurement and management of dyspnea. We measure dyspnea essentially by self-report and using activity scales, as well as we can have clinician rating and clinical indicators. And essentially what we're going to do to manage it is we're going to try and decrease the respiratory effort, make it easier to breathe, and decrease kind of the, hopefully, the chemical, the neurologic respiratory drive if necessary, and hopefully alter our perceptions of dyspnea as well. There are various scales that do allow us to grade dyspnea from grade 1 to grade 5. So this is the classic dyspnea scale. Grade 1 is you get out of breath with strenuous exercise. That's normal. Grade 2 is you're short of breath when you're hurrying on the level or walking on a slight uphill. Grade 3 would be walking slower than other people of the same age while being out of breath. Grade 4 is you stop for breath after walking 100 yards. And grade 5 is too breathless to leave the house or breathless when getting dressed. And lastly, it is important to recognize that there are age-related changes in the pulmonary system, and that there is a little bit more of a tendency to get out of breath as we get older. We have decreased elasticity of our lungs as we age. We tend to have larger alveoli, and we have increasing dead space and decreased surface areas. So again, we're not going to be diffusing quite as effectively as we did when we were younger. We may have hypertrophy of the bronchial mucus glands, so we produce additional mucus. We may have decreased respiratory muscle strength and decreased motility of the little cilia that are helping to sweep out the mucus in our lungs. So in general, shortness of breath and dyspnea are going to increase over time with decreased efficiency in our pulmonary systems. And that concludes this slideshow.